most comfortable with and which has the least complications. And approximately 20 years ago, people started placing in the prostate small radioactive pellets or seeds. And these were originally placed with an open operation. And then with the advent of ultrasound, they were placed without making an incision using the ultrasound. And most recently, in the past 10 years, with the development of computer techniques, these seeds are placed in the prostate with needles through the skin without an incision, guided by the computer, which calculates the correct dosage for the patients.
Now, with this type of therapy, and people also do well. How about their impotence and their incontinence?
We think patients have done very well with this. Again, the key is to treat patients at a very early stage of the disease, well-controlled disease. We found that the cure rate from the seeding is equal to the radical surgery and is equal to the external beam radiation. And the seeding is a procedure which takes about 40 minutes. We have at Los Gatos Community Hospital at the Silicon Valley Urology Center over the past years treated more than 6,000 patients, of which only 3 patients spent the night in the hospital after this procedure. To our knowledge, there were no postoperative transfusions, and our cure rate has been equal, we believe, to that of radical surgery. And this has been reflected around the country. The advantage to the patients is that there is no incontinence, and impotence is not a problem. Men will lose the ability to have erections with age, but the men that have been treated in this manner have the same course as if they had not been treated.
Now, in people who have prostate cancer, there's also the treatment of hormones. Tell us a little bit about that.
Yes. Prostate cancer can be controlled by removing male hormone. In 1936, Dr. Huggins in Chicago received the Nobel Prize for discovering that he could delay death and complications from prostate cancer by removing the testicles. And this for many years was done as an operation. Then men were given birth control pills. And that also decreased the amount of testosterone. But giving older men, like giving older women, birth control pills has great complications with strokes, so we stopped doing that. Now we have medications called LH-RH agonists, which prevent the production of testosterone from the adrenal glands and from the testicles, and therefore cause a chemical castration. This stops the growth of prostate cancer. It lowers the PSA. This form of treatment is used only when we think there is metastatic disease, or when the patient is not a surgical candidate or a radiation candidate. It doesn't cure everybody, or else we would use only this. And the reason it doesn't cure everybody is because prostate cancer, like most cancers, has a mixture of cell types and cell sensitivities. What happens in prostate cancer is that for a period of time, the majority of the cancer cells are inhibited, that is, they don't grow because of the lack of testosterone, but a few, maybe 1 in 1,000 or 1 in 10,000, will continue to grow, and eventually those are the cells that are going to cause metastases and complications, and this is what today is being defined as hormone-resistant prostate cancer. And great efforts are being made to treat these resistant forms with other forms of, with real forms of chemotherapy, with immunotherapy, so that there's great progress being made in this regard.
Now, in men with metastatic disease, you define that by having the bone scans and the various CT scans, MRI scans of the abdomen, and once they have metastatic disease, what can we offer these people?
These people are offered the hormonal treatment. If there is a particularly painful bone metastasis, short-term local radiation is useful for that. But mainly the great majority of these gentlemen do not need chemotherapy. They need this hormonal manipulation, and that serves them well for many years.
Now, once they have metastatic cancer, I guess, again, depends on the cell type, what can they expect with the hormonal therapy?
A great deal of variation. Again, as you say, depending on the cell type. We have patients, I personally have patients that have had metastatic cancer, prostatic cancer for 25 years and are maintained with intermittent hormonal blockage. Others, depending on the cell type, the survival will not be as good, and we will not be able to save others.
So the key is to go and have a screening starting at age 40 with the PSA.
Age 40 if you have a family history of prostate cancer. Today, a gentleman in our country today has a 1 in 8 chance in his lifetime of developing prostate cancer. If your dad, uncle, grandfather have had prostate cancer, you will have a 1 in 5 chance of developing prostate cancer. So that's why in the family members of prostate cancer victims, we ask them to start earlier. This is done also particularly in Europe, starting at 40. If you have no history of prostate cancer, then we would suggest at 45 or 50. If you are African American, because of the high incidence, the highest incidence of prostate cancer occurs in African Americans, and therefore I would suggest that they, even though they have no relative who has prostate cancer, should start screening at 45.
Now, we're going to wrap up our show, and so the take-home message, we have 1 minute remaining. What will you tell our home audience?
This is a curable disease. Today, finding prostate cancer early, we can cure about 93% with minimal complications, with minimal hospitalization, and with minimal change in lifestyle. So it really should induce men to overcome their fear of the exam with the urologist and come and be examined.
So, number one, if you have family history, at age 40, get screened. If you don't, at age 50, get screened, the PSA. And then have a digital exam by your family practitioner, and if there are questions, see a urologist, because obviously early is better to find this disease.
Yes. The family practitioner should do a PSA and do a digital rectal examination. If there's any question on any of these, then obviously the urologist has more experience and should be the treating physician.
Oh, well, thank you for joining us, and this has been very helpful for all of us to learn about a disease that can be cured early and that it affects 1 in 8 men. And so for next time, we hope you will come back. Next time will tell us more new treatments, and hopefully every year we will have more new treatments.
Certainly.
Thank you for joining us, and thank you to the home audience for joining us at Health Talk.